say this publicly, but our wards are fundamentally unsafe, but the technology that David and his team have put together is making our wards much safer. Open Innovation 2.0, one of the key patterns is platform. Building a platform. It's shifted from a product to a platform, and what David is building is a platform. And maybe if we do have a testimonial from one of the nurses. David, do you think we should play that, or should we go straight into the conversation?
We can go straight into the conversation.
Okay, we have a testimonial. We'll make it available online. But it's one of the nurses in Cavan who's been using it, who returned from the UK, was shocked to see how basic our wards were, and telling about how wonderful and how brilliant it is. But maybe we'll go straight to the conversation, David. So tell us a little bit about QS300 and your journey and what it's going to do for us in Ireland.
Okay, well, thanks, Martin. QS300 is basically a vital signs automation software solution. It's Class 2B certified, so it's software as a medical device. And it's made available to the nurses and doctors in any ward. We actually stay away from the ICU, which is already pretty well served from a systems point of view, but the other 95% of beds are in regular wards, and those are the ones that we address. And so that software is available on touchscreen, fully integrated with the vital sign monitors, whichever ones they're using for their rounding or wall-mounted or whatever, fully integrated there. So the solution is also fully integrated with the elements of the health information system within the hospital, be it the patient admin or whatever it might be. So that's what we have, and crucially, we have, through a huge number of iterative episodes with users in the hospitals, we've ended up with something that is embraced quickly by users because of the feedback they gave us and how we honed the usability of the thing. Usability is everything, as you probably know. These people are working, against massive resource constraints, are working in a very, very difficult situation, making decisions on the fly and the like. What we're doing is making it simple, reducing cognitive burden, and crucially eliminating opportunities for error. As Martin alluded to there, if you take the early warning score chart, which is a complex thing many of you may know, when you look at the audit results within the HSE, or indeed the NHS as well, it's exactly the same. The error rates are around 50% on charting and scoring, 50%. So when you talk about 10x margin, we actually deliver a 50x improvement in that regard, because the rounding is done faster, but crucially it's done at less than 1% error rate compared to the 50% error rate that's endemic today in a ward near you. So that's one of the crucial things, Mark.
It's brilliant, and the returns, David and I worked on the financial returns of this, and we used the value dials approach. I wrote a book on business value 15 years ago, and I've looked at hundreds if not thousands of business cases. I never saw a business case with this return, 1100% internal rate of return, payback period in 7 weeks. We tried to socialise this in the HSE, and there was no adoption. And Cavan signed up for a pilot, and we brought everybody to Cavan, and we got all the stakeholders in the room, and we were lucky to get Liam Woods and Dr. Michael Connor to agree to sponsor this. We're now rolling it out to 20 wards, but this needs to be in every ward in the country in the next couple of years. So I want to call out actually David's resilience, because every board meeting, every quarter, David and I would have a conversation. I'm saying, be patient, this is going to happen, this is going to happen. But the biggest testimonial I can say to this, Dave Byrne is here. Is Dave Byrne here from UPMC? Yeah. Hi Dave, where are you? Great. So UPMC, obviously one of the world's biggest hospital organisations, and Dave was in my office about 3 weeks ago, and we were going to be collaborating with UPMC. They're a fabulous organisation. And I was showing Dave, what David has done, and I said, look, this is what we're doing. I expect you have an equivalent technology. He says, no, we don't. I would love to, get this into a living lab environment at UPMC. So, what Orla Quinn talked about, this international exploitation, we have 5 phases, exploration, proof of concept, demonstrator, broad adoption, and then actually into international exploitation. So Dave and David are actually going to work together sometime today to figure out how we start a living lab, and that will be big exploitation. And that actually is a nice introduction to Roisin, because we're working with Roisin as well in Sweden and in Holland, using Ireland as a reference site. So we talk about platforms and Open Innovation 2.0. It's not about products. David and Myles have been very quickly able to implement RespiraSense into the Synchrophi platform that is used now in Cavan. It's going to be used, as it's used in Tala. It's going to be used in every ward where we deploy this. So we will go from the absolute laggard to world leader in this space very soon. Roisin, can you just tell us about the Bluetooth integration of your device and into David's, and how easy that was?
Yeah, so our device looks like this. The one we have currently in the market is green. That's the unconnected device. This is the connected version, which has been linked up by Bluetooth to David's system, and there's a cart here. So you literally just take the device, point it to the forehead, and the result will come up on screen. So obviously that can go to anywhere. So as soon as the reading's taken, it can appear in a screen for a doctor, a nurse, or for any decision making. And really one of the important points there is that all of the data is date and time stamped. It carries details of the actual device, the physical device itself, which for the engineers in the hospitals is really important on asset management and tracking. And it feeds all that into the system, so the engineers can do things like trending of data. They can look at the different, they can even check these by way of performance and so on, because they have the data captured ongoing. And of course, with all of this, when you have date and time stamps and actual accurate information on the temperature reading, this serves to give like a baseline for patients and adds more value. And really what this is about, I remember when we set up a company, we brought it to the first person and said, a thermometer, really? And I asked the question of this person, I said, what test is done in every patient, in every ward, for every condition, in every country, every single day around the world? Temperature reading. And that's what they use to track epidemics and pandemics, which we're all aware of now, unfortunately, more so. But multiply that by 4 cents. And that's what your hospitals are paying every day when they use thermometers, but they have to use a plastic cap which they stick on the end and put in their ear, their mouth, or somewhere else. So this has been implemented with the HSE team. We brought this to market ahead of COVID, so it wasn't just a COVID product. Because we'd identified, as Martin said earlier, the hospitals are way behind the technology. I've been in the medical industry for over 25 years, and it kills me to think that they're still writing everything down on paper. So really that was our journey, is to help the patient and to deliver accurate information. And trials have been done of our current device, which shows that that is inaccurate in one of the trials as an esophageal probe in a patient in surgery. And as Martin mentioned, we're working now with the Karolinska Institute in Sweden, where they've implemented this in their ECMO centre, and they're putting it into the NICU and the paediatric ICU and so on across the hospital. And also some of the other countries around the world. We're currently in 21 countries. The connected device, we've been working with David's team to get this set up, because at the end of the day, the platform's great, but you need accurate information, good detectors and sensors to put accurate results in to get the right diagnostics out. And that's what we're about, is to give them the most accurate and robust devices for use in the hospitals.
Oh, that's brilliant, and we're going to be hearing from Roisin later on. And then what role does Tala play? So for this technology, which is life-saving, which is going to increase capacity and reduce average length of stay, we spent 3 years trying to get funding for this in the HSE, and we're stonewalled. So we actually had to go to Deeper. We won a competition in Deeper, we got 50 grand, and people may know the names of Aodha, Halapanar. This will show you how dysfunctional the system is. So it was a HICRA recommendation that this kind of technology be deployed across the country. Nothing happened, and particularly not in Galway. So we went to Galway because we nominated Galway as the site specifically because of Savita. Ross Cullen was on my team, and not only was it rejected, he got beaten around the head for how dare he suggest that this would go into Galway. Like, the system, there is a lot wrong with the system. Unfortunately, some people interpret, and I'll be, a person sort of, unwelcome in Galway after this, but, the Hippocratic Oath, do no harm, is sometimes translated into do nothing. So I went straight to David, I said, David, look, we've 50 grand, can you do this? No bother. It's working fantastic. Catherine Wall, one of the clinical directors, hugely embraced it. And David, how's it been working out in Tala?
Absolutely fabulous, Mark. We initially, as you said, the €1 program deployed it to Osborne Ward. So we've done the model here, which is with the mobile carts, in a combination of common rooms and individual rooms, and the feedback from the nursing staff is absolutely fabulous. And it's all part of our overall principle and talent, which is about releasing time to care. And I think it ties in very well with some of the speakers who were talking earlier. So we have very highly trained medical, clinical, nursing, HSC professionals who have spent a lot of time documenting when they should be releasing time to care to spend more with the patient. So this is a perfect example now of where traditionally a nurse would have had to do the rounding, spend physical time doing that rounding, documenting that in the chart, and then obviously doing the calculations. Then if there's a calculation, they would then have to go onto the phone to contact the doctor, etc. So with the introduction now of Synchrophi, that has all been completely automated. And we're already now starting to look at where we can suppose align this with other technologies. So you talked there about the thermometer, but similarly there's discussions now going on with Vicera technology. So any of you who are familiar with Vicera, it's the, as we used to call it for the nerds there, the Star Trek badge, where you tap and talk, and it's really replacing now your common paging systems now. So what we want to look at now is, because we have to replace our paging system, is if we can link, and I think we can as of recently, we can link now Synchrophi with Vicera, so then it will automatically alert the doctor via voice message to them to the state of their patient. We're also looking, as you mentioned, integrating into our Evolve EPR. So while we have the central dashboards in the ward, what we want to do now is, is integrate that with the EPR. So anywhere in the hospital that if the doctor is out, they get notified of that. So it's been such a success now, we're now rolling out to a second ward under the national programme, which is the LIN ward, which is Respire Senses in it as well. And with that model, we're actually going with that's majority of the individual rooms, so we're actually going with the wall-mounted solution, which is right beside the bedside. So we're using both models, but the feedback, and Kate is very excited about, who's our Director of Quality, Safety and Risk, about where this can bring the hospital in the future. And we're actually getting very keen for it to be rolled out in the entire hospital. So releasing time to care, it's not like we talked, a lot of speakers talked about, different things. It's about people, process and technology, and this is a real people thing, because you are giving clinical healthcare professionals a tool that they want to use. You get adoption then, you get buy-in, but also it releases time to them to care for the patient.
Yeah, and what we're seeing here is a pattern of multiple 5x, 10x benefits. So on Synchrophi, on TriMedika, TriMedika is 5x, faster, 5x easier. You don't wake up the patient at night to take the temperature. It's 5x lower TCO. So we're seeing this pattern. I think we'll leave it at that. I hope in a year's time, clearly we'll be at 20 wards, but I'm delighted that Mike O'Connor is the sponsor and driver for this. Mike got it immediately, and I hope it won't be very long before we're saying we're putting this in every ward in the country. So congratulations, thanks for being so resilient, and I think that deserves a really warm round of applause. So hopefully you agree that this is new, it's novel. The next showcase is really important actually. It's almost my favourite actually. The stars actually was the best we could get available for the money available. So I'll leave you in suspense. But could we have Dermott and Anne and others up on stage, and if we could run the screening video, please. Not this video. The next video we're going to skip this, please, Connor. Life 10X is our national strategy to transform our healthcare system, and what we've done today here at Carroll and Mohammad is actually really historic. We are providing a screening process, a personal electronic health record, and an enrollment into a program where you use a Fitbit or a rotor device and have a wellness app, and this can potentially transform the health of everybody in Ireland and actually transform our healthcare system. Great. Well, we're really pleased to actually have three CEOs here. We have Mohammad, who is a doctor and founded a social enterprise called Patient No Best, and he'll talk about that in a second. We have Dermott Shortt, who is actually world sort of international banker, and he's been partnering with his sister Anne and Paul, Anne's husband, to do something remarkable around rapid screening. And then lastly, Jonh Carroll is CEO of Navi Group, who are the leading pharmacy network in the country. And there's a real opportunity here. I think out of this we can bring a couple of recommendations to the HSE board around the whole new process. We have so much COVID infrastructure. What's about to be described for a couple of, the cost of less than a cup of coffee per person is absolutely remarkable. But also the pharmacies are willing to step up. We know we're losing GPs at an enormous rate, but the opportunity for the pharmacy and the pharmacists to step up and take a bigger role in our network is hugely important. So maybe Dermott, would you start and talk about what we did? And this took 2 weeks to pull together.
Yeah, absolutely. So Full Health was started, as Martin said, over 10 years ago by my sister, who was an A&E consultant, and I simply got fed up of middle-aged people like me arriving into A&E presenting with a heart attack or a stroke, because in 100% of the cases she would say, well, if I'd seen you 6 months ago and taken your bloods or had some look at your vitals, you wouldn't be here today. So she took the opportunity to get on any soapbox, any radio station, any newspapers would listen to her story and say, look, we need to get really focused on preventative healthcare and people doing some basic checks. So we started a company that ran medical assessments for 10 years. Lots of decent clients, HP, Honda over in the UK, people like that. But actually what we've done in the last 18 months is turn the whole company around, and we focus just on the software piece. So the idea is to replicate the entire process for getting somebody into a room, running medical, getting lab results in, interpreting those lab results, and that's the most important piece of the IP, giving them back to the patient in the form of a health record, which then they own and they can share, and we've got really good examples of sharing this with Mohammad's company as well. And that's really what it is. It's about driving scale through this. If I can, I'll try and do this in 60 seconds, Martin, but a great story to illustrate this, even ahead of the example we had 2 weeks ago, was Honda in the UK, who used to give executive medicals to their execs at enormous cost, and said, actually, we need volume here, so we think about the 10x that Martin keeps talking about, and we need the cost to come down massively, because we want to give these medicals to the entire production line. They make cars, right? So what they did was they used our software, and the software does all the logistics and the hygiene stuff that is, you'd expect it. You can set up locations, like if Martin says, I want to run HSE medicals across the Southwest, there'll be programs like HSE 2022, Southwest, locations, we want to run them in various locations, diary and booking slots, and then you broadcast links and let people log on, so they'll create their link, they'll say, my name is Dermott, I'm going to book 2 p.m. on Friday, and you'll get a very small slot. And what I want to draw your attention to here is the cost reduction. Doctors traditionally see patients to perform medical assessments, and that is a linear activity. Patient comes in, we have a chat, some bloods are sent away, take some measurements. So the inputs you're getting there are answers that the patient's giving the doctor, so maybe question answers. The second type of an input into the medical is a metric. They've taken a blood pressure, they've taken a heart rate, they've taken the BMI, for example. And the third type of input is pathology, something back from the lab. And you can have hundreds of these if you think of all the various things that can go in there. And what we've done is we've automated all that, so patients can log on and create their identity and fill out questions. We did that at, like, I'm going to say, a few hours' notice. When Martin said, I want this done in Dunboyne 2 weeks ago, we had the whole thing set up in a couple of hours. So people were able to log on and book slots and then answer all the questions, not in front of the doctor, it's all done at home. Then they present to the room. In this case we used Care Plus up in Dunboyne, and you know, we didn't have a doctor in the room. Actually we did in our case, but we don't need a doctor, you need a phlebotomist or somebody who's qualified to get blood out of the person. That's basically what you need. And the point is you can have loads of those out there all coming back into the same data set, which is cloud-based technology. And then what happens then is the results are sent off to the lab, everything's integrated, lab results come back into the system. And then we do what a doctor would do. We interpret the results. But what we've done over the last 11 years is used doctors to inform algorithms to tell us what the output would be. Based on what I see here, this is what I would say to a patient. And we've gone a step further. We've used consultants to write modules for us. So if you have a cardiology module, it's written by a cardiologist who might ask slightly different questions than another doctor, and we have it peer reviewed and we put a lot of effort in there, so we automate all of that whole process. And what you get then is a doctor who's finally seeing the results. The report is already written for the doctor. So if you take the Honda example, one doctor would see 500 patients on a dashboard, and do you know what? 490, there's nothing going on. It's not interesting. The report's already written. I'll hit release and I'll release that report back to the patient, back to the humans, not patients, to use Ross's word from earlier on. And then the last 10, this is where the doctor might want to spend some time, because there's something going on here. It could be, and the system will bring urgent ones, there's a little phone icon that says phone this person right now and tell them to go to Italy, or it might be set up a video call and so forth. But the point I'm trying to make is we've done this massively cheaply, and we've optimized the doctor's time, which is one of the most crucial resources. So the doctor's only looking at the people that he or she really needs to spend time on.
It's brilliant, like 100x the volume, probably 10x, 100x the quality, and we're seeing this pattern all the time. Mohammad, you have a very interesting story. Why don't you tell it to us, and you know what part PKB actually have in this pilot?
Sure. So we were, my background is a physician program, as you said. I'm a patient, so when I was 16, a nurse called Helen Middleton trained me how to inject myself. And I can shift left, I can be at home rather than occupying a hospital bed. And then my doctors gave me my care plan so I can figure out how to look after myself. And I could stay home, stay left. Now I had that experience when I was working in the States, writing a book about how to give patients their medical records. And I saw all of these examples from places like UPMC and others, where if the patient had the data, not only could they look after themselves more cost effectively, they could look after themselves better than always ending up in their A&E department later on. So I wanted to bring that technology to everyone. I thought the main problem in the USA was the institutions wouldn't trust themselves, wouldn't trust the patient with the data. But if we went to the UK with the National Health Service, we could start proving that, and then governments all over the world could adopt that. So in 2015 was our big break. We had 2 million people's records. It's the first population to say we're going to trust people with the data, and that will be how things move around. That's now in over 11 million people's records in the UK, and it was a key part of the NHS app as part of the COVID response. So what we did together is, as you collect all that information and bring that report together from the doctor, it then goes with the patients know best. So it's with that individual human, and it's with them as they go to their family, as they go to their local doctor, as they go and plan what to do with their health, give them that information they must know. And that becomes a foundation for everything else they're going to do, looking after themselves and helping others who are looking after them.
Now, it's amazing because I think what we can do is actually completely re-architect digital health in Ireland, where actually the centre is the patient and their patient record, and we're delighted to have Dr. Philip Curley as the main sponsor for this. I hope Philip doesn't mind me telling this story, but he and Tony Houlihan were actually the 2 top candidates for the CMO, and Philip said, you know, that was one bullet that he was happy to pass. But Philip has been waiting this for 10 years, and I have my electronic health record on my phone. I was with Robert Watt 3 or 4 weeks ago, and you know, it took about 10 minutes for Robert. He said, look, this is fiction, you're not doing this. And I said, look, we'll get you a patient, your personal electronic health record within a week. Of course, I knew we could have it in 20 minutes, and he had it in 20 minutes. And increasingly there are stakeholders that are stepping up. Maybe we could do this. It's going to take some courage, but we could completely reinvent the way that we do care in Ireland, and having the patient at the centre with their own personal electronic health record. And Mohammad and I had a conversation about 3 or 4 weeks ago, and I gave him a deadline. I need to know in the morning, because I was meeting Robert that afternoon, need to know in the morning, what would it cost for us to do this per patient in Ireland. And he came back, it's a cup of coffee. And similarly with Dermott, we could do this for a cup of coffee per person. Does anybody know what the cost of a PCR test is at the moment? Professor Nolan, you probably know. I know it was well above the hundreds. I checked yesterday, it's about €59. So for the price of less than that, we can screen people, we can give them a personal electronic health record, and then we can get them onto a wellness program. We're going to be talking to Gerard Davis, CEO of Irish Life Health, shortly, and what Irish Life Health has done is something brave and courageous, and made the My Life Health app available nationally. I use it personally, I find it hugely valuable, but imagine if we were able to use this for every patient in the country. Jonh, you're CEO of Navi, and thanks for the fantastic engagement. We're hoping to open a new digital pharmacy living lab in Carroll and Shannon with Paul Reid, who part-time resides there later or early next quarter. But you were very resourceful, and you engaged with us immediately. Where do you see this going? Could pharmacies take over this frontline role and actually scale this if we do it nationally?
Martin, thanks for having me. And absolutely, I suppose, just to give you a quick background on Navi, Navi is a pharmacy and services management company. So what we do is we provide financial, marketing, support, purchasing services to allow the pharmacists to run their business more efficiently and to save time, to focus then on engaging with their patients. There's a huge demand from pharmacists to move away from the transactional, dispensing only structure, which the business has been structured up to now, to a much more patient engagement structure. So that's why we're very interested in engaging with Dermott and the team of Full Health Medical to actually prove the concept that pharmacy can be a destination where they can create a step change in the health of their patients from a day-to-day basis. So just when you look at the community pharmacy industry as a whole, there are 1,900 pharmacies in Ireland at the moment. There are over 6,000 registered pharmacists. Our pharmacy was very involved in the response to the COVID-19 pandemic. So just to take that as a simple example, there are now over 1,100 pharmacies which are vaccinating for COVID-19 in terms of initial vaccinations and boosters, and they've delivered over 800,000 vaccines to patients. So from a standing start of being the last group really into the initial centralised centres and then the GPs, pharmacy was the last group to start vaccinating. They were really able to ramp up, and there's huge flexibility amongst the community pharmacy sector. When in terms of patient engagement, there was a survey by Behaviour and Attitudes in September 21, and it said that 85% of patients or people in Ireland found the pharmacy was the most accessible source of healthcare information. They also have the longest opening hours. So we're out there as a group, and we're really able to engage with our patients. One of your previous speakers spoke about freeing up time in terms of what pharmacists are doing. If you walk into a pharmacy at the moment, a lot of their time is actually spent double entry. You have to take a prescription, you have to re-enter all the information the doctor has put already and re-enter it back into the dispensary system. So the advent of e-health and e-prescriptions would be a huge boon to the community pharmacy sector, because it would free up all that time to allow us to focus then on actually engaging with the patients even more. That said, about 75 hours a week are actually spent counselling patients and providing services, the majority of which are actually free of charge. So any patient can walk in at any time and get quality health information. So really, we see the development of new services and the development of additional services as really being a boon to the industry, but being a boon to our patients as well. So we're very, very happy to support this. And one other aspect of pharmacy, which is that every pharmacy must have by law now a patient consultation room. And we're involved in the development and the refitting of a lot of pharmacies, and over the past 5 years, the attitude of pharmacy has changed, so they want less space in front of shop now. The idea of selling a wide range of cosmetics and wide range of non-pharmacy product, that thinking has changed now, especially since COVID. So pharmacies now are large dispensaries, more patient consultation rooms, and less front of shop space. So they're really focusing on the healthcare aspect of their business as opposed to the retail aspect. And that's where we see the future.
Well, it's fantastic, and when I was talking to Robert Watt, he said that this is a great idea, but how could we scale it? I think using the pharmacy network, we could do the screening, we could give people a personal electronic health record and then enroll them on the wellness program. We could be the first country in the world to do this, and there's no reason. So I think that I've been making kind of a list of recommendations. We'd like to have a Tullamore declaration that we can put to the HSE board, 10 items. So I think certainly if you'd agree, the idea of integrated vital signs, in every ward, in every hospital, I think that's a recommendation. I think there's a recommendation that we should really scale up this proactive program. We spend just 3% of our healthcare budget on proactive care and health promotion. The UK is actually a leader, they're up at 8%. But our research and assertion with the work in the news is we should triple that. But the returns, the McKinsey's done a lot of work on this, but 67% of the opportunity in terms of quality of life and better outcomes and savings is in that 3%. So if we can triple it, it'd be huge. So what I'm proposing is your second recommendation would be to recommend this rapid screening process and a personal electronic health record, apply to every citizen in the country. If there's anybody that doesn't like that, could they stand up and tell me why we shouldn't do that? Okay, great, carried. No, seriously, we will send this out and send us your feedback. And you have this idea as well around the pharmacy stepping up. Tell us about the problem around GPs and what could be done around blood testing and so on, and have a more coherent network, because the future is IoT 4.0. It's network-centric healthcare. And what's your vision?
Thanks, Martin. So I have a good viewpoint on this probably because my day job is that I'm an emergency medicine consultant, as well as I'm dual qualified as well as GP, so I've seen it from all angles. And there is an absolute paucity of care in general practice. It's overwhelmed. There are no doctors coming through. The solution is always, well, let's train more, but what are you doing? You're increasing the GP places and you're lowering the bar. So, and in any case, there are many GP training places that are unfilled, even at that. For me, it's a no-brainer. You have a pharmacist, you have pharmacies in every village in Ireland with a room with the clinical expertise, and they're to do the health assessments in a pharmacy, to do the medication reviews, to do all of your primary healthcare bulk in a pharmacy. It makes complete sense in a world where there aren't any GPs. You ring up, you can't get a GP appointment, and yet you can walk into the pharmacy and you don't use it because the general public haven't learned to think that way yet about pharmacies. It kind of brings us to a conversation we had outside, which was, why don't they think that way? Let's say I find I have an abnormal blood pressure, or I'm getting a headache, I've got a nosebleed. Let's say I'm a bit worried, I'm a bit worried about my blood pressure. My automatic, the general population just think, well, I must make an appointment with my GP. It never occurs to you to walk into a pharmacy and get your blood pressure checked there and have a chat with a pharmacist with 20 years experience, because you don't think that way yet. And that would be what I would love to take. There are many things from your previous speakers that I really enjoyed, but on this point, to start to look at a pharmacy differently is going to have to take a big PR move on behalf of the HSE. And then the practicalities, you don't have, I don't want to speak out of turn, this is John's role here, but there are no incentives for pharmacists, there aren't enough pharmacists either. They need to be paid and freed up to do a clinic a day a week, and also they need to be trained in phlebotomy, because right or wrongly their point of care moves very fast, but if you really want to get the general public to view it as comparable to a GP visit, and frankly sometimes superior to them because they're not rushed, then you will need to do a blood draw. So two things, really simple. Get the HSE to pay to incentivise a pharmacy to run one clinic, one day a week, where they would take blood and do a 2-day phlebotomy course and you're done. It really is a no-brainer.
Well, that's brilliant. So I think we have another recommendation here. And just to tell a very quick story that probably few people know about, when COVID came, we had a 10-year barrier against being able to send a prescription electronically. But we pulled 5 people into a room, myself and Myles from the Department of Health. We pulled Darragh Loughlin from the IPU, Fintan Foy from ICGB, and Eileen Byrne, the CEO of Clonwilliam. Is Eileen here? She is. There's Eileen. And in 2.5 meetings, we actually had a decision that we were going to do this. We turned it on. The first day we had about 300 prescriptions. The second day about 800. By day 3, we were up at 20,000. Within a week, we were at 50,000. And Nina Burns actually sought me out at the Irish Healthcare Awards, and she came to me and said, look, we're so grateful. This is the single biggest change that has happened for GPs and pharmacies in the last 15 years, and was simple. It's just people coming together, and again, it's having the courage and conviction to do it. So let's take a third recommendation around the new model for the pharmacy, an increased role for the pharmacist, particularly around bloods, and we'll involve the IPU and the ICGB and come up with a proposal. So I think this has been a fabulous panel, so thank you so much, and we'll see where it goes. We have a few more slots if anybody wants to actually have this screening, get a personal electronic health record, get a Fitbit, a subscription to Fitbit Premium. It's in the room outside there. So please thank our panelists. So our next panel is really exciting. I have a question for that I've been wanting to ask Professor Richard Costello for, since I know him, how does he look so young? Because Professor Nolan told me that actually he worked under Richard in his first intern role. Conor, if we can run the short video and invite Myles, Des and Professor Richard Costello to the floor, please.
Respiratory rate is well established around the world as a vital sign. It's one of the things you measure to ensure that the body is doing what it's meant to be doing. When there's something wrong like an infection, your body tells your lungs to breathe faster. Respiratory rate is one of the earliest indicators of deterioration. It's as important as how many times is your heart beat a minute.
So the ability in a general ward to measure respiration rate really is a game changer. It's one of the most significant innovations in vital signs automation that's happened in 100 years.
The purpose of Respirosens is to fill that technology void with a reliable tool that can be part of day-to-day delivery of excellent care.
In the past, respiration rate was very subjective. We have an ambition in Ireland to move from being a digital health laggard to a digital health leader.
We're trying to develop a tool for frontline workers to accurately measure the essential vital sign so that the right care can be delivered to the right patient at the right time.
We're able to work with PMD to actually build a business case for deploying this technology rapidly.
We've learned an awful lot from this journey in working collaboratively with the HSE and the digital transformation team. Our call to actions is to get respirosens on many patients as possible to improve the outcomes of respiratory compromised patients and to position this technology as the de facto standard of care in respiratory compromised patients.
We're looking for improvement in the quality of care, improvement in the quality of life, improvement in the clinician experience. We hope that the Irish healthcare system, through working with companies like PMD Solutions, can be leading and show the way for how digital health can be transformative globally. Great, just to mention, actually the Irish Times Innovation Award is being announced on Monday, and PMD are one of the shortlists. So good luck with that, Myles. Maybe to go to you, Richard, Professor Richard Costello. You're an innovator, huge, international sort of reputation. But when COVID came, you sprung into action and Myles showed up at Beaumont, and within a couple of days you were testing. Tell us about that experience and what value it's provided.
Thanks. Yeah. Well, I might be international, but I'm not on the sanctions list, at least. So COVID came, and one of the things that we had little notice of, the Chinese had done some literature, and one of the things that we spotted was that the blood pressure didn't change in people who were really, really sick with COVID, which meant that the most objective tool that we were using in looking for people who were deteriorating was unreliable. We always knew that breathing rate was the softest and least recorded of the vital signs. This opportunity not to have to go into the ward, into the patient who had an infectious disease, potentially lethal or at least harmful to the carers, meant that having an objective tool that was non-invasively being recorded continuously was of value. Having Myles appear, you guys appeared and innovated and implemented in Beaumont was extraordinary. But what we could see in Beaumont and what we're seeing now is, and I'm hearing the resonance with the other two platforms, is the ability to detect many hours before the person deteriorates. Because in a way, you don't really need a tool to tell you that somebody's sick. That's what doctors and nurses are trying to do. What you really want to know is when somebody's going to get sick tonight or tomorrow. And that's where this system comes in, because the breathing rate goes up hours, 10 hours, 12 hours before the person deteriorates. And that's where the genius in this is, and integrating this with the rest of the digital monitoring. Like the previous speaker said, frees up the staff to do the stuff that they're really there to do, which is to care for the patients, not document things. So it's an amazing system, and Martin, you've been a fantastic leader in bringing these people together, and I think we should all really applaud you for that, and that we have. Yeah, it's a great system.
The number one success for many IT projects fail, estimated 70-80%, but the number one factor, and through the work we've done at IVI and the Newth, is having a senior sponsor that cares and does what it takes. And Richard, you cared and you just went for it, and it's been amazing. Over to you, Myles. Overnight success takes on average 10 years. Tell us a little bit about the story and why this actually is world leading.
Yeah, I suppose I love to start these things in an audience by everyone breathing out as much as you can. Deep breath in, hold it for 2 or 3 seconds, and then breathe back out. So follow my hand. So breathe out, breathe in, hold it, breathe out. That is the impact breathing has on your state of mind, on your health, and on your well-being. And as Richard shares, everyone knows respiratory is such an early indicator of decline, but measuring it reliable has been the crux of the problem into over 170 years of manual recording of respiratory rate. So for the last 10 years, we've been part of this journey to revolutionize respiratory monitoring by making every breath count. And a number of years ago, we stopped selling a respiratory rate monitor, and we started focusing on solutions for preventing respiratory failure. We're now in our 3rd generation product, and this is where we got the call to action for Beaumont. And we went in, we worked with the team, we installed the equipment, and we got it working. And our philosophy is that this is a team sport. So being on site, working along with the front line, understanding the information that's coming out, and being able to interpret it in an actionable way, that caught on really quickly. And through the testimonial of Richard to the HSE, we got the opportunity to show that insights beyond Beaumont, starting with Cork University Hospital and then going to a national implementation. For us, the big difference is we're not selling a widget. We're selling a solution, which is part of a team sport. And having people on the ground, keeping that communication going, keeping that engagement going, that learning, we're constantly learning, we're listening, and we're adapting, we're remaining agile, has remained why Respiroscience has now gone beyond COVID and has now become part of the managing of respiratory compromised patients from COPD or otherwise. So I just wanted to highlight that point.
Yeah, and Myles, is it helping internationally, having Ireland as a reference site?
Hugely. Before COVID, we were in the Middle East and England pilots, very similar to how we commenced with BOMA, and we have to obviously stop that. Borders closed, we couldn't get access and all the rest. Within a few months of restrictions lifting, we have our first contract with Nottingham University Trust for 3 years, for 2 hospitals, 3 wards. Now that would not have happened at such an accelerated rate if it wasn't for the credibility behind the Irish healthcare system to endorse this transformational technology and attack a deficiency in how we measure respiratory rate with the focus of improving patient outcomes by making it a direct count. So yes, we're starting that beyond Ireland ambition now, and I think the credibility profile is definitely increased as a result of our collaboration.
So I think it's a great example of not just a health strategy, but an enterprise strategy. And actually, Des is our digital clinical innovation lead. We're a very small team. We're actually just 5 people. We are about 1/3 the size of the office of the CIO HR department. We're 100th of the size, but through partnering, we're using an exponential innovation methodology, but everybody has multiple roles. Des is the digital clinical innovation lead. He also leads our design thinking practice. We get some help from Aileen Colleen, and Des actually led the deployment of RespiraSense to 23 hospitals in 4 months. One of the leading clinical engineers in Beaumont said in the past this probably would have taken 5 years, and the fact we could go to 23 hospitals in 4 months, it was a team effort. Myles and Myles' team and Des and myself and others, we met every day driving, and there was, Des had to go out to Sligo, I don't know, about 4 times. You have to show up to, convince them, but it was remarkable. But Des is now taking this technology with Vera Keatings, who's a consultant in Letterkenny, and Antoinette Doherty, an AMP, and just before Christmas, Des and I were down with Myles, and we saw something remarkable. Do you want to talk about that, Des?
Sure. Thanks very much. Just firstly, I would like to say this. It has been a bit of a roller coaster the last year since I first met Myles. And like he said, this digital innovation transformation definitely is a team sport. It wasn't me or Myles that we probably met 12 hours a day, 7 days a week for quite a while. But I would say that we had a really good, rigorous project management structure in the background in terms of clinical governance, right from Professor Richard Green, Richard Costello, Aodha Casey, early morning score, we were writing the nursing side of things. But key to us actually in the success of all this, and every speaker has probably said this morning, is about the people. And for myself and Myles, it was like, who do we go to? Because we didn't know, in the middle of the pandemic, driving around the country, being stopped at multiple checkpoints. So where are you going? Yeah, okay. But it was about finding the well-connected, influential person within each hospital, and about trying to work with them to bring about that peer-to-peer influence, to share with them the benefits of what we were trying to do. And it could be a clinical engineer like it was in Kilkenny, it could be a few miles across the way in Wexford where it was senior nursing staff, down in Waterford it happened to be a respiratory consultant, but that's what it was. But it was about working with those people, and that for us is the benefit of that. Martin has just mentioned about Letterkenny. So we feel that the next logical piece of this is how can we take this, stay left, shift left, how can we do this in the community? So with Vera and Antoinette down in Letterkenny, we're working on remotely managing patients who have chronic respiratory illness in their homes. And we did have, so Martin has said that we were down in the corner, and we were, so we had 5 patients when we were doing technology testing with the patients over a week to see how they adopted and how they adjusted to it. All of these patients were all oxygen dependent, so it was like they took to it. So every time they walked from their chair to the sink or to the bathroom where they peeled spuds or whatever it was, the respiratory rate went up. But we could see this live feeds down in Myles' office down in Cork to see this. So this is the type of technology that it is, and this is what we want to do in Letterkenny with that cohort of patients. But keeping them out of hospital, keeping them well, keeping them at home, to get that early intervention and to be able to predict when that deterioration, that exacerbation will kick in.
So I think maybe the 4th recommendation we might take from today is, we're now in 23 hospitals, which is fantastic. We need to think about, do we go to other hospitals? But I think there should be a strong recommendation about moving this, across the community. Richard, how would you feel about that? Does that make sense?
Yeah, of course it does. I mean, you want to shift left and stay left, then the community is the place to do it. And obviously you need to integrate with the rest of the vital signs and minimise the documentation burden to allow nurses and doctors to get back to what they went into the profession for. And the biggest testimonies on this system, and I heard it from Tala as well, was allowing the nurses to get back to enjoying being nurses, because we've hemorrhaged staff recently.
Great, and just one final example, because this is about seeing is believing. This is stuff that's real patients. Des is running a design thinking workshop with Antoinette and Professor Vera Keatings, and Myles, Eamon Costello, who is the CEO of Patient Power, is not here today. But we had to knock some heads, and Eamon said, look, I don't think I can integrate this, for Thursday. And we had a conversation. There's no choice. You have to have Respiratory Patient Power integrated, and you shipped up a device. And then Sheila Gleeson, who's the country manager for our PMD, she walked into the room wearing a Respiratory device, and we were showing her respiration rate on the screen. And at that moment, Vera and Antoinette said, I get this. They couldn't picture, what was being proposed until they saw it. So seeing is believing is really important. It's fabulous work. Good luck, Myles, on Monday night, and we'll be listening out for that.
Excellent, thank you.
Great. One wonderful story, actually. Semper Fidelis, I don't know if people know that. I had the privilege of working with the Marines many years ago in California. Semper Fidelis is always faithful, and that's kind of a principle we use in digital transformation. But Myles was up for a big award in the Burlington and graciously invited myself and Des along. But he was refused entry and was stuck in his room. So anyway, we figured out a way of getting Myles into the event by going through the kitchens and so on. So you have to walk the talk as well. Our next demonstration, and hopefully we're way behind schedule, but this is so valuable. I think we absolutely should continue. Next project is really exciting. We have two serious heavy hitters, Centric and Roche, and we've had a fabulous partnership. So if we can just run the video, and if A and Len can come up to the stage, we'll have a quick conversation.
Heart failure or heart insufficiency are terms used to describe a heart that isn't working as well as it should be. There are over 90,000 people living in Ireland with heart failure today. It can affect anyone, but the incidence does increase with age.
Heart failure for me is something that I feel every day. It's like being trapped in your own body. You don't have the same energy as what you would beforehand. I'm not able to do the same activities that I would have done. Every day affects me.
Heart Care at Home is a new program providing home monitoring to patients with heart failure. Using the specially designed Heart Care at Home app, patients are asked to record their clinical data.
We found out about the Heart Care at Home app through our local nurse, Aodha. She said, look, give it a go. So we gave it a go, and it's amazing. I just have to enter my weights, my blood pressure, and how I'm feeling.
We will provide you everything you need to measure your blood pressure, heart rate and weight at home.
All of these can change as their condition deteriorates. So I would look at those readings on an individual basis. If the readings are a little bit off, we ring the patient and we discuss those changes in the readings with them.
You feel like there's someone there that will talk to you about it.
If anyone's heart rate goes high or blood pressure, when she enters that into the app, maybe half an hour, there's somebody on the phone, to let her know there's something wrong.
It's like you have this big support system.
Our Heart Care at Home nursing team will monitor your data and let you know if you have any medical concerns. We will support you to manage your medications, and we will aim to improve your symptoms in your own home. By monitoring and managing your heart failure more closely at home, we aim to optimise your heart failure care and improve your symptoms and quality of life.
Great, this has been a fantastic partnership with Centric Health and Roche. You are the country manager here in Ireland. COVID actually has taken out actually Dr. Moss Cox, who's the CEO, Donald Bailey, who's the Innovation Director, and Eva. So you're here. Yeah, so tell us about it and why Centric Health is so interested in this, and invested, because both companies have put a lot of money into this. Would you believe this is the future of heart care and other chronic diseases?
Yeah, and I'm delighted to be here today and support this whole initiative. And I think Centric Health is a network of 70 odd practices right across Ireland. And I suppose for us, Centric Health's founding vision was actually to keep patients healthy, not just get them well once they get sick. And this is where heart care at home fits for us. And I suppose unfortunately for a patient that has heart failure, it's a terrible disease and can lead to their conditions deteriorating quite rapidly. And when that happens, it often ends up in having to be admitted to hospital. And on average, once they're admitted to hospital, they're staying in for around 11 days. So what we've seen, and actually it was there just at the very end of the video, we didn't quite get it, but the evidence we've captured since we've rolled out this program is an 80% reduction in those hospital admissions. So the sort of the clinical outcomes are transformational for the patients. And I suppose from the patient perspective, we've heard the testimonial there from one of our patients. They love this program, and for them it's transforming how they're living their lives. It's giving them a huge peace of mind knowing that someone's looking out for them all the time. And from the clinical care perspective for the GPs, because I suppose we're a GP organisation, that link and that joining up of that sort of information sharing back to the patient's GP, that's improved as well. So their own GP knows what's going on with their patients all the time. Again, improving the health outcomes for the patients.
It's great, and it's again the 10x factors. We're not just seeing almost a 10x reduction in hospitalizations, 10x probably more reporting, because you're getting several readings a week. So instead of being screened maybe every quarter or 6 months, you can see in real time how a patient is doing, and those interventions by you have a nurse line identifying weight going up, being able to prescribe a new diuretic or a different type. It's fantastic, and because you're sort of a national organisation, this is something you think could actually scale across the country. And we're delighted Orla is here. Orla is the lead for, and we'll be talking afterwards, she's the lead for chronic care across the country, the equivalent of Mike for acutes. And maybe Orla, I might ask you to comment in a couple of minutes, if you wouldn't mind, on the potential for this, because this could be another recommendation. But maybe Len, we've had a fantastic partnership with Roche, are involved with us in another few other living labs. What's your motivation here, and where do you think this could go?
Yeah, so people might be aware of Roche from a pharmaceutical perspective predominantly, but also we have a very strong part of our company in the area of in vitro diagnostics, and even some of the work presented earlier regarding the pharmacy health screening would evolve around that testing for HbA1c and other parameters linked to diabetes. But when you stand back from it, in our company we look at the whole concept of doing now what patients need next. And that philosophy allows us to reinvest continuously back into innovation. The way healthcare is moving, it's all about integration. It's the integration of healthcare. It's also very important to have the right tools to do so. And I guess that's what brings us into the context of digital transformation, because everything we hear today in this forum, it's all about that integration piece. It's not so much about providing a test to do something or a respirometer to measure oxygen saturation. It goes beyond that. It's the impact factor. So over the last number of years, we've evolved that mindset, and we connected with Centric. It was one of those kind of snap moments. It's exactly what Centric are looking at, is that integrated care model that they want to bring out in the context of heart failure management within Ireland. And then we connected with Martin and the team in the HSE. It provides a great environment for Living Labs to constructively develop this program with the mindset of Living Lab towards national adoption and scalability. But to do that, it involves multiple stakeholders, and one of the value pieces that I guess Martin's team really brings to the fore is the whole concept of access to the right stakeholders to ask the right questions of what we're doing. And because it's a co-joint venture with Centric, we get those opportunities to meet with different parts of the health system to get those questions addressed, to help us then shape that proposition moving forward, particularly towards scalability.
Great. So unscheduled, Dr. O'Reilly, would you mind sort of letting us know your thoughts on what the potential this is? I'll bring you over, Mike.
Thanks, Martin. I'm just understand 10x now, right? What you're doing there is really exciting, and I suppose from my point of view, from an agency point of view, looking at integrated care for prevention and management of chronic disease, which is the program I lead, this sort of technology obviously has a very important place, but I guess I really focused on the integration element of these things that I've seen in the past, monitoring devices, put on patients in a not very organised way. So obviously you need to select patients that are fundamentally close to the high-risk patients, and the monitoring of them obviously has to go back to a professional. You have a nurse there, but that professional needs to be integrated with the community team that we're putting in place, and also with the general practice team. And I suppose it's that human piece that is not that easy to do. So, I think this is the future here, but for selected patients, I don't think it's kind of monitoring the whole population, or even the population of people with particular diseases, particularly high-risk patients. I think we need to monitor, because monitoring is time expensive for professionals, and but technology obviously does that mostly. So I'd be talking a bit small for a short while this afternoon about this, but I really feel what we're doing here on the technology enablement is really important, because we don't have enough healthcare professionals of all types, even now, and we certainly won't have in the future, to manage chronic disease. So we are going to have to exploit and scale.
Fantastic, Dr. O'Reilly. And would you maybe be able to put into words if there was a recommendation you would think, actually, Monica, can you leave the mic there just for 1 second? If we were to recommend, some form of recommendation to the HSE board around this, what would it be?
That we should exploit e-technology to complement chronic disease prevention and management programs that we're currently implementing.
Okay, brilliant. So we'll document that and we'll put that out to everybody. So I know we're running kind of slightly behind, so I think we'll finish at that A, and then thanks so much. So please, a round of applause. So Monica, from a lunch standpoint, can we go one more? Or what time do we need to move for lunch?
1:30.
Oh, 1:30, okay, brilliant. This next one is really, really exciting. One of the first people I met when I joined HSE as CIO was Professor Colin Doherty, and he got data and digital and has been doing some fabulous work. And well, actually, we'll tell the story in a minute. Why don't we run the video, and we will have...
Actually, I need to do a few slightly different. I need to talk a little bit before the video. Is that okay?
Okay, actually, so we're completely unscheduled. We're going to do one thing before that. PhilipLee, who's one of the top lawyers in Dublin, has told us that actually if he isn't in Dublin Airport by 3, he will be divorced. So we're going to ask Philip and Jonh, because one of the important things around innovating, it was very difficult for companies to innovate with the HSE, and we've had fantastic support from Jonh and some of his team. Brendan would of late we've been working with Philip and his team, and Philip is leading this personally and has come up with some new instruments and some new ways of thinking that can allow us innovate without doing sort of heavy procurement work that protects us all. So I think we're going to have Jonh and Philip talk about this process, and Philip, you owe us a coffee for saving your marriage.
Thank you very much.
So I don't know, Jonh or Philip, which you want to lead off?
Maybe. I'm very happy to go first. All right. Firstly, thank you, Martin, very much for including us today. I'm, in a way, having a lawyer here with such scientific and highly intelligent people seems a bit wrong. So the fact that you chose a lawyer to talk at this session says a lot about you. You can judge later on whether it says a good thing about him or about me, or a bad thing about him. But we've been the lawyers to the HSE since before they were created, also the lawyers to the Data Protection Commissioner before they were created, and since they've been created. So big data and treatment of data in a health setting is something that's very close to our hearts. And some of the things that your earlier speakers said resonated with me in terms of getting really good quality advice to liberalise how you treat data, because it does need to be used effectively, because data is a big issue obviously in terms of how we how we look after people's health. We've also just completed, with the help of Siobhan Dunphy, the EHR, almost completed the electronic health record system for the CHI. So we're quite in your space, aside from working through this particular project. People who know Martin know that he's going very fast, and time is a real commodity that he recognises. And lawyers sometimes don't recognise that commodity, but we certainly do, having listened to Martin. And I see Martin as driving a very fast vehicle on a motorway, and basically my role is to be the motorbike outrider. My job is to make sure that Martin goes at the speed he wants to go. And sometimes I'll see a traffic jam ahead of Martin, and I see sometimes a traffic jam in terms of procurement rules. So my job, with the help of Jonh and his team, is to find that detour, which if the traffic jam is a procurement process to develop a new product or service, we'll take Martin on a side road using the flexibility of the European directives to say, this is actually a co-financed research project. We're trying to invent something innovative. People think that the law system and lawyers are trying to slow things down, but in actual fact, when it comes to innovation, and these rules come from Europe, this is so much in their space. They are actually pushing for the state to do more of this flexible co-financing, collaboration with people to produce new product in Europe. So the directives are very generous. They allow Martin to pick up the phone to people and work with them, where we're not fully paying for everything, it's co-financed. We're not owning all the IP rights. The IP rights will be discussed, and that allows you to bypass the very slow rules for procurement. Now sometimes Martin may want to do more than develop a product and then be required to do a tender to actually put it out and roll it out nationwide. Martin may be driving not the fast car he wants to drive, but is actually driving a juggernaut, and that juggernaut is actually to go from idea to actual national rollout. And once again, the European rules provide a by road for me to go with that juggernaut and start a process which does result in a public notice going out there to call for people to come. Tell me how innovative you are. Tell me what kind of research and development teams you have in your organisation, that you can convince me that you can actually develop the solution that I have identified. And in a very flexible way, negotiating in terms of how much we might pay them during that collaborative process, going from 5 or 6 people maybe to 2 people, eventually 1 person, where they work out the manufacturing cost as well. And from that process, which is very flexible, you can actually go straight into the rollout. So you actually do a deal there and then with the person that has shown the best ability and progress during various phases to give me the product and the price, and I now just sign that contract without further delay. So that juggernaut that Martin is now driving can go all the way with a fast national rollout. Now, we worked on a whole pile of issues during the pandemic, and a lot of the brilliant things that you've been talking about came out of the emergency of the pandemic. So lawyers like us also have a helicopter available when Martin gets into real trouble, and we used it a lot during the pandemic to lift him out of the car and fly him by helicopter using what's called extreme urgency. And it isn't something that you want to use all the time, but we're in a unique situation where you're dealing with health. So during the pandemic, whether it was for the vaccination rollout or the development of the PCR test, we had to use that all the time. And so that's another tool that's available to both lawyers and to Martin if something really urgent is coming where you're saving lives. I should say also that I listened to some of the talks about the social impact as well. I was a guinea pig in the Care Plus test, and I got my report. And I know Gordon Doherty thinks he's kind of sporty. I'm actually probably much more sporty than Gordon, and probably consider myself much fitter.
More dangerous with that sort.
Much more dangerous. Yes, I'm not a big fencer, not the biggest national sport, not quite as big as rugby yet. But my report came back telling me what I knew for the last 10 years, that my cholesterol levels was slightly high. The report was very interesting because actually it linked my slightly high cholesterol 6, where it should be just at 5 or below 5. But it told me something I didn't know before. It told me that my heart age was 5 years older than I thought it was. And the competitive nature of me, actually, even though I knew this for the last 10 or 15 years, overnight I changed my behaviour completely, because I was not prepared to have somebody who was the same age as me, but I had an older heart than them. So the competitive social aspects of that had a big impact on me. So thank you very much for that.
No, great, and if you can't measure it, you can't manage it. That's what Peter Drucker said. Just a tiny story on PhilipLee, our first face-to-face meeting, very nice new offices, well done on that. But when we walked into the office, the first slide was there. The creation, or innovation is the creation and adoption of something new which creates value for the organisation or persons that adopt it, and then underneath it was Baldwin and Curley 2007. And it had me at that moment. They had done their research and they'd figure out what we were thinking about innovation, how we defined it. So that was great to do that pre-work. We've got on great, and no, Philip didn't have the charisma of my class at birth. He definitely has charisma.
I was a clever lawyer called Patrick Kane who works, and you found that for me. Actually, I grabbed it then, but somebody else found it for me.
Brilliant. So thanks. So Philip and Jonh, you're going to start now, but we're hoping to publish just a one-pager, which will be joint between Procurement, PhilipLee and HSE Digital Transformation, which will explain this new process and will make it easier. So we're hoping over the next 1 to 2 weeks to make that available.
1 to 2 days. I'm working with you, Martin. I know 1 to 2 weeks doesn't count. 1 to 2 weeks. So we have a pin notice ready to tell the world what we're doing. So people who want to participate in your great experiment can go onto the HSE portal, see what's happening, register their interest, and try to collaborate in projects that may have started or come to the team with ideas. So it's very transparent in terms of what we're trying to do.
Great. Jonh?
All right. Well, I think now it's procurement's time, and I think I should start with the breathe in, breathe out again, because everybody has that image, and it reminds me of the time when I was in Cork, and I was having lunch one time at holidays, and somebody asked me where I worked, and I jokingly said social welfare, and half the pub left, so procurement can have that effect on people, but I'm here to say it's different. It's very different. We heard the Minister talking this morning about patient care and trust, and it's all about patient care. Everything that we've done over the last number of years, and we're in procurement a long time, but everything we do is about patient care, and it's about working together, and it's about joining that up. The vaccination programme, congratulations to the NIO on getting that wonderful award in conjunction with GS1 last night on all the work they did in the track vax, and they're examples. Professor Philip Nolan mentioned the cider system, and when I heard cider first I thought of Clonmel, now so I'm getting an image of myself here, with the Bulmers or whatever, but the cider system was a dinosaur. And thinking of the clinicians to have the volume of testing coming through, and had we not got the robotics in place, that would have been an absolute disaster. And I know the information may not have been perfect, but we did have tests and results and so on the following morning on time. So that was where, if you like, we came into play. On the patient trust and patient image, probably the HSE has grown a little bit, but that allows us from the learning. We've been through Brexit, we've been through the pandemic, not out of them yet. We had the cyber attack, and now we get reality with the Ukraine. That brings us all back to reality and saying what's really important. But health is really, really important, but it has taught us an awful lot in the journeys that we've gone through there in a very short space of time. It has taught us that we can work together, we can make things happen, and it changes our culture. And what I think what we have to do with procurement is we have to become influencers up into government. And what I'm saying there is money isn't everything. But when you think of the investment, the small investments and the engagements of the marketplace and the health service, and the lawyers getting us through all the different hitches that we can go through, and we can do it very easily. What can happen? Isn't it amazing? But we have to start influencing people upwards to stop getting into rule books. Like I'm plagued with audits since pandemic. Philip mentioned Article 32. Everybody knows Article 32. It's the only article they know in the directives, but they all know how to get out of something, which in actual fact there's lots of rules and regulations that we can actually help with. And if we do it in advance, it's much easier for us all. But we have to get away from rule base, as in rigid rule base, and we have to be fluid and flexible and creative in the way that we think, and we're there to help that. Now, if you like, the culture has changed. Our board and our chairman was speaking, Kieran was speaking earlier on, and he's really behind this. Our CEO and our management team are all behind what's happening on IT and innovation, so much so that we've had a chance to look at procurement from our point of view and say, right, where are we placing our resources within this? And I'm happy to say that I'm finalising a 3-year plan going forward, and we're putting about a third of our resource into IT and innovation. That's our commitment. That's going to be led by Siobhan Dunphy. Just in case you don't give me loads of cards, give them all to Siobhan and keep the work going. But that's our commitment. So we're looking forward to all the different things that are happening. I'm delighted with Dr. Roisin Molloy earlier on getting finally through all the quagmire. We said we would get there eventually, didn't we? And it's brilliant, and what a fantastic initiative it was, and saving us an awful lot of time, and all the good things that were coming about, infection control, all the benefits from what I would call a simple but really, really important initiative. But we're here to help from a procurement point of view. We have our colleagues in Philip, and that's what we're here about, so that's it.
We will keep that car moving at full speed with the
Yes.
outsiders flashing. I just think of that.
That's it.
Well, this was great. So this is another example of open innovation 2.0. The technical people, the clinicians, the lawyers, the procurement organisation, making it easy. In the past, when I came to the HSE, I felt it was the mission to actually shut down some of our suppliers. Actually, probably my saddest day at the HSE, well, probably my second saddest. We had a company called Carroll, running a living lab in Cork and in Waterford. There were 3,000 older patients being monitored using this program. They actually had a shared care record, which is what the country has been looking for. And during COVID, we actually had every senior clinician in the country lined up to actually expand this. We could have had a shared care record for everybody in the country in 3 months. And unfortunately, the governance mechanisms stopped that. And as a result, we've moved governance, all of the decision making away from IT, and the Department of Health unfortunately had a role to the clinicians. So now every decision on rollout of digital solutions is actually driven by a clinician. So it could be Mike, it could be Orla, and then when we get to broad adoption, we bring in Vaughan O'Neill and Lee Woods. But unfortunately, the CEO of Carroll had to write to me and said, look, we've had a discussion at the board, and we have decided that we can't continue to work with the HSE. It's just so difficult. And I still have that email. I thought about showing it on the screen here, but my ambition is that will never happen again. So to Owen and his team, who did fantastic work, and probably, maybe they'll just be about being paid after 3 years. We have to apologise, but that won't happen again. And thank you, kind of, for fixing this. So brilliant. Thanks, Jonh.
Thanks, Martin.
Have a brilliant holiday. Where are you off to go? So we have time for one more demo. Colin, do we need to change something before you start, or should we run the video?
We haven't got some slides, but I can just go ahead. I'd rather talk a few minutes before the slide then.
Before the video. Okay, brilliant.
You do, yeah? Yes, you do. Okay, everyone, so we did have slides, but I'm just going to talk off the top of my head. So I'm delighted to be here. My name is Colin Doherty. I am a neurologist for the last 30 years. I've spent 25 of those years working in epilepsy care. And today we're going to present a very real-world video of a patient interacting with the healthcare team using a digital record. Now, what's most important, the first takeaway point from this is not a new figment of the imagination. Okay, this is happening. For 15 of those 25 years, I've been embedded in digital records in epilepsy care. I haven't used a piece of paper in epilepsy care for the last 10 years. Okay, so what we're talking about here is not stay left, shift left. It's stay left, shift lefter. Okay, we've been doing this. We've been delivering the 10x agenda. We've been delivering on stay left, shift left for a decade. And what we're talking about today is a re-platforming project. So inevitably, when I started in 2004, just going back to Philip Nolan's computerization, 2004 we started as a research and development group with a group of clinicians and scientists in Beaumont. And I remember talking to my non-medical friends and saying, so we've got this brilliant idea. We're going to take patients' records, we're going to computerize them, and then the doctors will have easy access, and then ultimately patients will have access to them. And I get this kind of blank look. I mean, we're not doing that already. So that was 2004. So if you think digitization in healthcare is a problem now, think of what it was like in 2004. Okay, that's 18 years ago. So what inevitably happened was, after many, many years of using the same platform, we've realised now there's a need, first of all, from a technological perspective, to re-platform it. We have to re-platform. The old Oracle system is no longer supportable. But we didn't want to just re-platform, we wanted to reimagine our healthcare, digital healthcare. Because we weren't talking about AI, machine learning. We weren't even talking about patients accessing their records significantly in 2004. But we've done a huge amount of work around that now. We've had a patient portal running, we've published in the international literature. So we're now moving into an area where we want to take advantage of cloud computing, of machine learning, of data analytics. And so what you're going to see now is something we do every day, but it's a new system. And what we're trying to do is develop, well, I'll talk a little bit about after the video. So I think if you want to go with the video first. So actually, before the video runs, one final thing to say. So the people in this video are a patient. Her name is Maria Carty-Mole. Maria is playing a patient persona, so it's not her data, but she is a patient, and she's been working with us for the past 5 years on co-design projects. So this is a real world scenario. We've about 10 patients that we regularly use to help us decide what the patients actually want. So she's going to be the patient, and then the clinician is Cora Flynn, who's an advanced nurse practitioner in epilepsy. We have the highest rate of advanced nurse practitioners to patient ratio in Europe. We developed that program as part of the epilepsy. So you'll see these two people interacting, and then I'll talk a little bit for a few minutes after it. So go ahead.
Good morning, everyone. My name is Rebecca. I'm a patient with temporal lobe epilepsy. It has been with me for 8 years, and I'm going to be showing you the new portal today. Because of the type of epilepsy I have, I feel it is important to work with the epilepsy team to bring in the patient perspective. I'm used to a service where I have made contact through email or phone, and I'm used to having a high level of interaction with the team using the portal system in the past. But I understand that there is a new version of the system available now. So I'm demonstrating today how I can access all the information relating to my care and how I can contact the team when I have something to report. I can log in on the homepage, and this is the desktop version. Then this is my homepage after I log in. What's great is that we can also get this on mobile too. The rest of the demonstration will be using the mobile view. I can access the timeline and all my previous requests and their statuses. Let's look at what I can access on the menu. I can see details of my personal information, my demographics, contact details, my epilepsy. To show you a bit more, I can see my medications. And the helpful thing here is it shows which ones are active, which are not. There are a number of health assessments that I'm now able to do online, for example, diet or lifestyle assessments. Now we've seen the various options. Let me show you one feature where I can report a recent event. This has happened in the last week. I'm going to report the side effects that I'm having from my medication. And I expect that someone from my care team will see this and respond to it. What's good about this is that I can provide specific information about my side effects. And if I want urgent attention, then I can designate this as severe. This will make a red light appear on my case when Dr. Doherty sees it. Now that I've submitted this, I can go back to my homepage and see that latest request appear. My care team will be able to access this information in real time and respond to me as applicable. Now, in the next demonstration, you will see how the agency team are going to receive this side effect notification that I've just submitted and how they will work through my request. Thank you for watching.
So my name is Cora, and I'm an epilepsy nurse working alongside Rebecca's epilepsy team, and as part of my role it would be to respond to the messages that come in from people in the community when they're experiencing difficulties with seizures or their epilepsy medications. So as Rebecca has sent a message to us, I'm going to respond to that, and I can see up on my work list in the top left-hand corner Rebecca's message. And I can pick that up to manage that in the service. My workflow can also show a dashboard of other graphical pictures of what's going on in the service on this particular day, which can be flexibly configured. But back to Rebecca's message, which is now inbound, and I can see on the right-hand side all the detail that Rebecca has shared with us about her current symptoms, which I can see that she's on the Lamictal 150 milligrams morning and evening, and the symptoms that she's now complaining of. What's really important about this screen is I can view a very rich, detailed medical history of Rebecca. On the left-hand side, I can see her past medical history, her allergies, her medications. And in the middle part, I can see a detailed history of her previous medications and her current medication doses, her start dates, and the maximum dose that she was prescribed. On the right-hand side, which is really important to be able to view Rebecca's epilepsy syndrome and the causes of her epilepsy. And this screen shows me all her rich, detailed medical information that I require to respond to her message without having to navigate several IT systems or use several usernames or passwords. On the right-hand side is a repository where all our letters and our encounters are reposited, and I can view them and look at the last people that interacted with Rebecca. This again gives me a very detailed account of her medications, and I can see that recently from the repository of letters that her Lamictal dose was increased, which may be contributing to her current side effects. I can now create a care plan to advise Rebecca on how to resolve these symptoms. I will be contacting her for some more detail and to communicate that advice to her also. This page shows me a journey of her epilepsy care and the timelines. And this page shows me all the people who are involved in Rebecca's care, including her clinicians and community pharmacists, and can be configured to include other relevant people involved in her care. The beauty of this system is that at a push of a button, a lot of information appears for me to review in order to respond in a timely fashion to Rebecca's side effects. I hope that's helpful for a visualization of the system, and thank you for listening.
Thank you. Couple of things, couple of points about that. This is a very real world situation. So this is not something that certainly the technology we're demonstrating here is something we want to investment in. But what we do every day is this. And I keep talking to Martin. Martin tells me, Colin, is this 10x? Is this 10x? And I keep telling him it's 100x. I mean, any clinician in the audience will know a patient calls in, somebody takes a message, oh, they've got a problem with their side effect. The nurse has to go and get the chart out of the chart room, then they have to look at it, they have to check it, they have to go back to the patient on the phone, they have, all of that stuff. This is all done in real time, okay? And this is what we're doing every day. And so 10x doesn't do it for me, it's 100x. Okay, that's the first point. The second point is that this process we've been undergoing at the moment is a proof of concept. So we've been working with the IBM Salesforce team for the last 6 weeks to build this system. And I'm directing this to Aodha, right? This is the integration tool you need. Forget about epilepsy, right? Just think of any chronic disease here. This is a very, very rich medical record. Okay, you can think of any chronic disease, diabetes, heart failure, asthma. Think of them all in this system here, all in the one place. Think of all of your wearable devices that have been talked about today that download into this system and are integrated into this system. This is the tool you're looking for. And by the way, we've been doing it for 15 years. We're not saying give us this and let us play around with it. We know how to do this. Okay? So one thing that came out of the couple of talks earlier, and I have so many points to make about some of the other speakers, but if we want, what is the key messages that we want to bring from this talk? One was about ethics and transparency. We literally wrote the book on the ethics of EHRs. I have published in the last year and a half in the international literature on the ethical frameworks applied to EHRs. If you want that, I'll give it to you. The second point is, you know, Martin talks about being laggards. There are laggards, and we're the laggards of Europe in relation to IT. I don't feel that way in relation to the service I've been running. But Martin will tell you that's true, but it's not widespread. But here's the point. If you're going to spread it wide, please nurture, look after, encourage the people who've been doing it in the desert of digitization 15 years ago. We've lived through, like, it's amazing to me to sit and talk to an audience of people who kind of know what I'm talking about. You know, people just didn't know what we were talking about. No, that's never going to happen. We're not going to get rid of handwritten records. That's, you know, medicine is there's too many ethical issues. You know, it's not going to work. We're not going to be able to put stuff in digital form. So to be here today talking about this, so you need to nurture the people, and there are others, and I can name them. That's the unfortunate thing. I can name the other people who've been doing it for 15 years. But they need to be nurtured. They have embedded learning, and it's not just me. My whole team are the people that you need to be talking to. Because in the people, process, and technology, everybody's talked about it, it's the people. It's the people that's the hard bit. We know the technology's there. The Salesforce, IBM people have been fantastic. Their technology is amazing. But we know that's there. The processes can be written down, but the people, the engagement with the people, that has to happen from people who've been through the journey. So thank you.
That's inspiring, and I was going to say, when I joined as the CIO, Colin was one of the first people I met, and I was inspired. And I think, Colin, you have actually one of the largest sort of, you know, longitudinal electronic patient records for epilepsy, and if we can actually get that into the new system, it will be amazing too for research, wouldn't it?
Well, we collaborated across with one of the partners. I'm a PI in the SFI-funded Future Neural Centre based in RCSI. I'm a TCD PI there. And we talk regularly to our colleagues across the world. They can't believe the repository of information we have. So we have about a quarter of all the patients with epilepsy in the country. We have conservatively 50,000 years of patient data now. And we talk to our collaborators in the US, they're going, that is unbelievable. They cannot believe the repository of information we have. And our goal over 5 years, if we can get this technology funded, is to have 30,000 patients in the next 5 years. And that's going to be, I can't see it being replicated anywhere in the world. So that's what the promise of this is.
Yeah, and one of the key things, actually, there are a couple of things that are novel around this, because we changed the procurement process with the help of Jonh and Brendan White. And in the past, HSE always wanted to own all the IP and sign your life away. And we said, no, this is going to be shared IP, we're going to co-design it, and companies are able to exploit it. So we put out a PIN notice. Thanks, Siobhan and others for doing that. We had more than 50 expressions of interest, and we had actually 7 companies present prototypes to us that they developed at their own cost, and we were able to assess them using the stay left, shift left criteria. We were hugely impressed with Salesforce and IBM, and literally, you know, we talk about 10x, 100x, it's fantastic to hear that. This is way more than 10x faster, because, you know, with Cheshire here and Seamus and Suzanne from Salesforce, literally in 4 weeks, and, you know, HSE, Des has been involved. We've been doing sort of daily stand-up meetings, you know, having epics, using the Scrum methodology, and what has been produced is really remarkable. It took 1.5 years for the original epilepsy EPR to be developed, and Ergo did a fine job on that, John Purdy, but it's very old technology, it's falling over. Now, not only have we got something that's re-platformed, which was very necessary, but we also have a solution, as you say, is 100x better. So really want to acknowledge your leadership, and Cora and IBM and Salesforce have really stepped up and, you know, really pushed the boundaries. So as Colin said, this potentially could become something that goes into diabetes, goes into all of the other electronics. So what we're doing is taking options. This could be a very valuable option, and if it is, we'd strike the option. If not, we'll let it expire, but everything so far is looking good.
Just one origin story of this whole process with Salesforce. So I had a patient with very, very bad epilepsy. During the pandemic, I actually did a house call to her because we couldn't get her into the hospital. And I met her brother there, who's Paul Colleen, who's an employee of Salesforce. And he said, look, we have this thing where we give the discretionary days from work, to help people. Is there anything I can do on the IT side? And I said, well, you could re-platform the whole EPR. So poor Paul went, oh, hold on a second. But the point was that little story, that embedded story, that true story led to this. And I want to thank Suzanne and Salesforce team for doing that. And finally, the last person to really thank here is Maria Cartimol. I mean, for us, it's just day to day. As soon as we think about something we need to do, we ask our patients, is this what you want? Tell us what you want. So working with patients is just central to everything we do. And any presentation I do, the patients get central part in the thanking process. So I really want to thank Maria for doing that. She was at a wedding today. She would have been here. Not her wedding. That would have been above and beyond the call of duty to do that video. But thank you.
One patient story was actually the use of the patient portal, and your patients were involved in the co-design, and one of them, Simone, I won't mention her surname, but lovely lady, but she was hospitalized for 4 months during COVID, and she was able to use the patient portal and work with the doctors there to actually manage her treatment. No, for no other chronic disease is that kind of capability available, and that's what we want, the patient empowerment. And she said, I don't know how long I would have been hospitalized if I didn't have this information and could work with the doctors. So brilliant. We are going to have to figure out how we fix the agenda in the afternoon, but with your appreciation, we're going to continue because we have some stunning demos that are game-changing. We're going to move upstairs. We have dinner. We actually have a small award ceremony. Before we start with the next demo, we have 3 collaboration announcements, and all our other speakers, really keen to get Ger Davis on board, and we will figure out how to do this. So have a nice lunch, network, and we'll see you back in 45 minutes, so probably about 20 past 2.
As was said already, out the door, up the stairs, on the right hand side is the Millennium Room, that's where lunch is.